Good morning. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. It's my pleasure to welcome you to our event this morning with the elegant title of Health and Housing Needs for U.S. Seniors in the Middle Market. You'll be hearing a lot about the middle market today. If you can come up with a better description, we'll take it and run with it. It's our pleasure to be releasing the paper that forms the centerpiece of our discussion today, entitled The Forgotten Middle. Many middle-income seniors will have insufficient resources for housing and health care. We're also releasing two companion perspective pieces. You'll hear from their authors today as well, who are not only responding to the work in the paper, but offering comments from their own work as well. This is a very exciting moment for us at Health Affairs. We have many roles in the healthcare discussion, and the work that we're releasing today hits a number of those, and that's what makes this job so fun. The work that you're going to hear is cross-cutting. It's looking at health, but it's looking at social supports, what those of us in the field often call long-term services and supports. It's looking, of course, at housing. You hear that in the title. And then it's looking at those in the context of the other needs that people have. The cross-cutting work is unique and important, particularly given this topic. It is, of course, empirical. It's data-driven. We bring research and evidence to the policy discussion, and that's really the other element. It's policy-focused. You will not leave today, I assure you, without a lot of questions in your head. Okay, this is a pretty scary reality that's coming toward us. What can we do about it? We will not answer that in its we won't answer that fully today, but we assure you that that will be on your mind and on the minds of the speakers. And all of this comes together in the primary role that we like to play at Health Affairs, which is an agenda-setting role. This is a topic that it's easy to wait. It's easy to think we'll solve it later. It's easy to set aside in the face of other priorities, but by releasing the empirical, policy-oriented research, we are able to put this on the agenda and hopefully yield additional discussions, policy-oriented discussions, as we go forward. We couldn't do this event without the National Investment Center for Seniors and Housing Care, as well as the SCAN Foundation, the John A. Hartford Foundation, AARP, and the AARP Foundation, who've supported the publication of the research and the forum. Their support is critical to, as I say, not just the analytic work that's represented here, but also the ability to bring folks together. And as many as you are in the room, I can tell you that there are more than twice as many who are watching us live through streaming, and we will archive this, and there will be additional viewers into the future. So without any further ado, because we have a lot of material to cover today, and I want to make sure that we get through it, I will turn to Bob Kramer for some opening remarks. He's the founder and strategic advisor to the National Investment Center for Seniors Housing and Care, a nonprofit education and resource center that serves debt and equity investors interested in the seniors housing and care industry. Mr. Kramer, I'll turn it to you for some welcoming remarks.
Thank you, Alan, and good morning. Thanks to all of you for coming, and to those of you listening online. Appreciate your interest in this topic. I want to particularly thank Health Affairs and their editor-in-chief, Alan, their executive publisher, Jane Hebert-White, and all of their team. It's been a joy to be able to work alongside of them and support this effort, and we really appreciate their shining a spotlight on a topic that has received very little attention, both from the policy and research arenas as well as from the private sector. And that is what we like to call the forgotten middle. And that's what we're going to be talking about here this morning. Just a word about NIC. We are, as Alan said, a 501c3 education research and data analytics organization. Our mission is to advance access and choice in seniors housing and care for America's elders. And we do that through what is a somewhat, some might say, unusual approach, and that is to focus on capital and particularly educating sources of capital, both debt and equity, for both for-profit and not-for-profit seniors housing and care. So that's our focus, our particular interest is to bring the investment community to the table, to develop options, to develop solutions to some of the issues that we'll be highlighting, and then to have the private sector in constructive dialogue with the public sector, and we'll talk more about that later. We've been pleased to provide a grant to NORC at the University of Chicago and their research team led by Caroline Pearson for the actual research that the paper you'll hear about this morning summarizes and brings to the fore. In addition, we're pleased to be able to provide support with our partners, the SCAN Foundation, again, the John A. Hartford Foundation, AARP Foundation, and AARP for not only this briefing, but overall the dissemination of this information and really the beginning of a conversation. I want to stress, which perhaps will be obvious by the end of the morning, this research just sort of scratches the surface. It's like sort of lifting a curtain back just a little bit to see an issue that no one's really paid attention to. We are not giving all the answers, far from it, nor do the paper's authors have all the answers. But we're saying continuing to ignore this is at the nation's peril, at seniors' peril, and it's critical. And it's also, it imperils our safety net and social support programs that we do have for the poor in this country, and particularly for poor elders. So with that, I want to turn it back to Alan for our program. Again, thank you for coming, and we look forward as NIC to working with so many of you in the audience in constructive dialogue to move forward in addressing the issues and the opportunities and challenges that are going to be highlighted in this morning's discussions. Thank you.
Thank you so much, Bob. It's now my pleasure to have the authors of the central paper present their work. You're going to hear from Caroline Pearson, Senior Vice President at NORC at the University of Chicago. I knew NORC when it actually we have AARP here. We have all these organizations that used to stand for something that are now acronyms, but there was a day. You still stand for. There was a day when NORC was the National Opinion Research Center. David Grabowski, Professor of Healthcare Policy in the Department of Healthcare Policy at Harvard Medical School. I do have to say I overheard them as we were starting. Typically when we have events where we release papers, we give the authors 7 minutes. You guys have 20, and you were like haggling over, can you get another couple of minutes? The answer is we're being quite generous, but it's because of the importance of the topic, and I think the methodological complexity. You are bringing in data from multiple sources and trying to weave it together, and so we are pleased to give you 13 extra minutes. But use it wisely. I think, Caroline, you're going to start. Oh, I'm sorry. David is...
can we bring up our slides?
Yep.
Oh,
yeah.
There we go.
You want to come up here?
Yeah, either way. Do you want us to do it from here?
I think it's
okay.
Preferable up here.
All right.
For the camera, it's nice for them to be.
Okay, great.
We'll get you. It always takes a minute to get here. Sorry, refuse.
Bob, you get to come back up again and do another. No.
All right, there you go.
Great. Well, good morning, and thank you, Alan. Today's presentation is really about, and today's session is really about the forgotten middle. And of course, by the forgotten middle, we're referring to middle-income seniors and how they've largely been excluded from the market for seniors' housing and care. They've been forgotten by policymakers, they've been forgotten by private industry, and they've been forgotten by researchers like myself and Caroline. Today is about beginning a dialogue and hopefully an agenda around targeting care and housing to this middle-income population. Let's see.
It's just a little lagged. But
oh, sorry, maybe I'm...
It will get there.
Oh, did I? Maybe very lagged here. Did I press it correctly, Alan, or I don't, is it? Oh, maybe it's this. Oh, there we go. Perfect. Alan's going to be my technical assistance here. Caroline and I are going to tag team this presentation. We're up here on behalf of a team of co-authors, Charlene, Cy, Rupa, and Beth. And once again, we'd like to acknowledge and thank the National Investment Center for supporting this research. One of the key facts of long-term care is that individuals want care in the least restrictive setting possible. Nobody wants to go to a nursing home. And so it's a real balancing act between meeting individuals' health care needs versus maximizing their quality of life. We know older adults have a series of health problems, cognitive and physical impairment. Yet, in spite of these issues, they want to maximize their quality of life. They want to be around their family and friends. They want autonomy and control over their environment. And obviously, they want access to health and long-term care services. Here we go. Seniors housing can help balance these trade-offs. It can break down some of the silos that we currently have in place in the system by providing, obviously, access to a social network, long-term care services, and medical services. By senior housing here, we mean assisted living and independent living. So we cite a number in the paper. There are roughly 2 million individuals currently receiving seniors housing, about half of those in assisted living and about half in independent living. Oh, there we go. More than your health and your preferences or desire to live in the community are going to dictate where you receive services. Here I've just presented a continuum, an income continuum. On the left there we have lower income seniors, in the middle income seniors, and to the right those higher income seniors. As you can see, one's finances play a role in where you end up accessing services. Family caregivers are important across the continuum. But for those lower income individuals, they have access to Medicaid, to low income housing, to a series of programs for dually eligible beneficiaries. For higher income individuals, they have access to private pay senior housing and in-home caregiving. That middle income group, however, is our forgotten middle. They're too wealthy for that subsidized housing and Medicaid, yet not wealthy enough to afford extensive private pay options. What they typically end up with is a mix of family caregiving and some spend down to Medicaid. So ultimately, they become lower income seniors themselves. Why do we think this problem is going to grow over time? Well, think about how middle income individuals are financing their care today. They're relying on some savings and some family caregiving. We know that future boomers are going to have less in the way of pension wealth, and so savings is likely to be lower for future cohorts. And we know that in terms of demographics, they're going to have fewer family caregivers. Marital rates are going down, and individuals are having fewer children. So some of us might think, well, gosh, that just means we're going to push this over to Medicaid. My response would be good luck with that. We know Medicaid's already a strained program with more and more elders in the baby boom cohort. I don't think we can rely solely on Medicaid as the solution here. So what's our objective today? It's basically to examine the future cohort of middle-income boomers in the year 2029. We're going to focus on seniors age 75 and above for our presentation. We're going to answer 3 questions. Who is this population? What will their care needs be? And will they have sufficient financial resources to access seniors housing? And with that, I'm going to turn it over to Caroline, if I can. I'm going to just give this to you and say good luck.
Ta-da! So step 1 in our work, and I want to first just mention, we used the health and retirement study using 2014 as our base year. That was the most current available data at the time we conducted the analysis. And we needed to start by really determining how we were going to define middle market. And what we really wanted to do was create income cutoffs that were based on this cohort that David has described, which excludes those who are likely or may be eligible for Medicaid and excludes folks who may have other options available to them through private pay as a result of their resources. We ended up focusing on that 41st to 80th percentile based on individual income and assets. And for folks 75 to 84, that runs from about $25,000 per year to $75,000 per year. For the 85 and above cohort, it's a little bit of a wider range from about $24,500 per year to $90,000 per year. And we think these are relatively conservative estimates, really trying to make sure that we're not picking up folks who might have other options available to them. I lost it. There we go. I'd like to just give another shout out to my colleagues Rupa Datta and Sai Laganathan, who really led our thinking about how to construct this model. And so what we did, because we're looking at folks who are going to be 75 in the year 2029, we needed to back up 15 years for our 2014 cohort and start by looking at people who are 60 years and older today. We then needed to create a mortality model to anticipate which of those people will still be alive in 2029. And we did that based on a variety of demographic, socioeconomic, health, and mobility factors. And the remaining cohort really constitutes our seniors in 2029. From that point forward, we wanted to understand the healthcare characteristics of that population and what their needs are going to be, given that those needs are really going to drive their ability to remain independent in their home and whatever care and housing options they may need to consider. So what we did was we looked at rates of chronic conditions among current seniors by socioeconomic and demographic subgroups. And then we assumed consistent prevalence rates in the 2029 group based on those subgroups. We know that certain conditions like obesity are becoming more common in the population. Other conditions may be becoming less common, and so we simply didn't have enough literature at this point to assume any changes in prevalence. And then lastly, we wanted to understand what the financial resources of this 2029 seniors population was going to be. And we took a bit of a different approach on this than what lots of literature has done in the past, and we wanted to look at individual income because we felt that that was more closely tied to each person's life expectancy, their health needs and ability to remain in their homes independently, and what kinds of care needs they might have and medical costs they might have. So we took household income, we divided it among spouses where appropriate, and we combined income streams with assets that we annuitized over life expectancy. And that together constituted our individual financial resources metric. We then took those original financial resources based on the actual savings patterns, retirement savings, 401ks of that 2014 cohort, and we projected it forward based on historical growth rates. And so that was really what the overall methodology was for our projections. So what did we find? Well, we found that as the baby boomers begin to age into this demographic group, we see this massive projected increase in the number of overall seniors. And I'll draw your attention specifically to that dark blue segment, which is our middle market segment that's projected to grow from about 8 million individuals today to 14.4 million in 2029. I'll point out that this is really just the beginning. In 2029, the oldest baby boomer is going to be 83 years old. So as we think about the 10 to 20-year window, all of the patterns that we've laid out here are only going to grow and accelerate. Looking at demographics, we find that the future senior group is changing just like the rest of the population. They're becoming more diverse. We see racial and ethnic minorities increasing from about 9% of today's seniors to 16% of future seniors. On a positive note, we also notice that future seniors are going to be more well educated. So we see an important decline in rates of people who haven't graduated from high school, and a marked increase in the number of people who have a college degree or higher, 38% in the 2029 cohort. And that educational change is really important because it actually drives a shift in the distribution of financial resources. Future seniors, on average, are going to be a bit higher income because we've really reduced that very low income cohort that's driven by lack of education. Another important point that we saw, David raised this, lower marriage rates expected among future seniors. And given the important role that spouses play in helping people remain independent in their homes, that may have a big impact on the needs of this population. The other thing that's going to drive the needs for housing and care is really health and mobility factors. We know that as people have more chronic conditions, have more health complexity, and begin to have cognitive and mobility challenges, it's harder for them to live independently. They require more in-home care or potentially to leave their homes. So I'll call out a couple of statistics here. We found that 2/3, 67% of future seniors will have 3 or more chronic conditions. 60% of them have mobility limitations, and 20% of them are projected to be high needs. And we defined high needs as having 3 or more chronic conditions, as well as 1 or more challenges with activities of daily living. So again, this sort of begins to help us understand some of this large and growing cohort are really going to need additional supports. And then lastly, if they do need additional supports, what options are available to them based on the savings and financial resources that they have available? So again, this is where we looked at folks' income sources as well as their annual assets, and we compared it to a threshold of roughly $60,000 a year, which we used as a benchmark for a typical cost of medical out-of-pocket costs plus rental levels for an assisted living facility. Now, I'll note that those costs vary widely geographically, they vary widely by facility type, and obviously out-of-pocket medical costs vary widely by people's individual health needs. But I think the findings are quite telling regardless. We found that 81% of this middle market cohort will have insufficient resources to afford that $60,000 threshold. And if we include their house, so if we assume that they're able to sell their home and annuitize those assets, still a majority, 54%, have financial resources below the threshold. So those findings really do begin to call out the relative lack of options that we see among this group.
Great, thanks, Caroline. So just to kind of summarize the key takeaways from the results of the paper, we estimate over 14 million middle-income boomers age 75 plus in the year 2029. This cohort will be more diverse, more educated, and have higher levels of chronic illness. And the majority of these individuals will be unable to afford seniors housing based on the current market offerings. So how do we begin to address this forgotten middle? We argue in the paper, and I hope I'm beginning a discussion today, that it's not just going to be a private sector solution, it's not just going to be a policy solution, but it's going to be a joint public-private solution that's ultimately going to address this issue. I'd like to sort of tick off some of the possible kind of private and public options that we have in place that may help to begin to target services to this forgotten middle cohort. There we go. So let me start with some ideas on the private side, and I'll start at the top and go clockwise here. And these are some ideas we put forward in the paper. But ways of potentially growing the private market. We know to date most senior living communities have focused on higher income individuals. Is there an opportunity to actually have mixed income communities where there's some units directed at higher income individuals, some at middle income individuals potentially? What about the role of technology as a way of potentially lowering operating costs in this sector? Is there a way to do some substitution for staffing potentially? At the very bottom there, many other countries leverage family caregivers in seniors' housings. We do very little of that here in the U.S. Is there an opportunity here to better partner with families and volunteers to offer a lower price product for middle-income seniors? And finally, we often bundle the price here in the U.S. for housing and care. Is there an opportunity to unbundle that price and actually offer sort of a la carte, here's your housing, here's your different care needs, as a way of making this more affordable for middle-income individuals? On the policy side, and this is really where our heavy foots are in terms of solutions here, there's a real role for government solutions. And I'll start at the top once again and go clockwise. There's been a lot of interest of late in blended kind of housing Medicare products. Many assisted living companies have started their own Medicare Advantage plans as a way of bringing services to these communities. From the perspective of middle-income elders, it's a way of potentially making this more affordable in that the assisted living company isn't just providing housing, they're now also a health care provider there on site. I should also note that just this year, Medicare Advantage allows long-term care to be provided as a supplemental benefit. And that might be another way to kind of leverage some health care in many senior living communities around the country. Moving down to Medicaid. Medicaid is an important payer of assisted living services. They pay nationally about 10% of all services. However, they only pay for the services that are delivered, the long-term care services that are delivered in these communities. They're not allowed by statute to pay for any of the room and board. So this is a real barrier, as you can imagine. For a beneficiary, you have to qualify for Medicaid, yet have enough dollars left over to actually pay for your housing. In a high-income state like Massachusetts, where I live, that's very challenging for providers to actually offer a large kind of Medicaid product because, for the most part, individuals aren't able to have enough dollars left over to pay for their to pay for their housing. So we could think of, from a policy perspective, of relaxing those rules or varying those rules. And then finally, we know that there's some, maybe not enough, subsidized housing for lower income individuals around the country. Is there a way of extending this kind of program, the tax credits and advantages for communities, to middle income individuals? Obviously, we don't want to crowd out what's happening for lower income individuals right now, but rather complement the existing programs that are in place for lower income individuals with those tax credits that might be directed towards middle income individuals. So Caroline presented a lot of our projections, and obviously there were a lot of assumptions. You may have quibbles, maybe more than quibbles, with some of the assumptions we made. One thing we're really proud about is that we've developed an interactive tool that's going to go live next month on the NORC website. So if you don't like anything we did in terms of you can do it, you can redo it yourself and actually put in your own assumptions and put forward, and you can see the screenshot there. You'll be able to make these projections yourself. You can vary the assumptions we made around housing and medical costs. We presented data on 75 and older today. You could do 85 and older. You can do 75 to 84. So there's a lot of variables there. You can include housing equity. You can exclude it. So you can put together your own set of estimates, and that'll be live next month. So please keep an eye out for that. Just to sum up, and then I'll turn it back to Alan, we argue that there's this growing need for senior housing options among this middle-income cohort. Based on the existing options that are out there in the marketplace, many of them can't afford seniors housing. In order to address this issue, once again, I'll assert, it's not just going to take policy changes. It's not just going to take kind of increased private sector attention. It's going to take, I think, a public-private partnership. And so with that, Alan, I'm going to turn it back to you and say thanks, everyone.
Thank you for that thorough and clear presentation of the findings. I'm now going to ask Jack Rowe and Jennifer Molinsky to offer comments. We're publishing their perspectives today as well. If you want to come up, why don't you all stay, because we're going to have a panel with all four, just so everyone's clear in the audience. We want to get the perspectives out on the table as well, and then we'll have a panel with all of our authors. So, Jack, I'll turn it to you first. Jack Rowe is the Julius B. Richmond Professor of Health Policy and Aging at the Columbia University Mailman School of Public Health, trained geriatrician, former chairman and CEO of Aetna, among other extensive high points in his career. We will then hear from Jennifer Molinsky, Senior Research Associate at the Joint Center for Housing Studies at Harvard University. So, Jack, come on over before you get settled in.
Thank you very much, Alan. I'm delighted to be here. I want to congratulate Health Affairs and the NIC for shining a light on this neglected area, and congratulate Caroline and David and their colleagues on this very, very interesting work. I have been working for over a decade with a group of colleagues who are interested in various aspects of societal aging. We call this group the Research Network on an Aging Society, and I'm here to present a perspective of that group. This includes, some of these names may be familiar to some of you, Axel Borsch-Suppan and Martin Coley from Europe, Lisa Berkman, James Jackson, Tony Antonucci, John Rother, a man who looks very much like John Rother in the third row there, J.L. Shansky, Frank Furstenberg, Linda Fried, Laura Karstensen, and Dana Goldman. And this is an interdisciplinary group. We work very hard together. We have had very generous support from the MacArthur Foundation for the first decade of our work, and continued very generous support from the John A. Hartford Foundation, which has supported some of what I'm going to show you. I agree that this is a neglected area. It's a forgotten group. That's symptomatic of the fact that, at least in this town, policymakers, when they think of aging, think of Social Security and Medicare, and the discussion more or less ends there. I'd like to step back from housing for a minute. Housing is critical. We'll hear more about housing, and think about financial security from a broader point of view. And here's some data from the Employee Benefit Retirement Institute, and this is the probability of not running out of money. This is not can't afford housing. This is can't afford anything, okay? And this is by different income groups, and that highest line, which is in green, is individuals, men age 55 with an annual income of $65,000. And this is what they would have to save in order to have essentially a 50% chance of not running out of money. This is the impact of two important trends. One is continued low savings rates in individuals, and the second is what we call longevity risk. People are living longer. And as you can see, most people save 3-4%. We'd like them to save 5-6%. They're not going to save 12% or 15%. It's not going to happen. And for women, in this slide, it's even worse because their longevity risk is greater. They live longer. And so they have to save, starting at age 50, if someone has no savings, which is quite common, by the way, because they've spent their money on their kids' education or their parents' well-being, they'd have to save about 20% a year, starting at age 50. If they were a middle-income woman, in order not to run out of money. So financial security, in a broader sense, is really important. And that brings us to some of our work looking at various aspects of how well societies are adapting to the demographic transformation. With the support of the Hartford Foundation, we have developed a multidimensional index which looks at 5 principal domains that I'll review. We don't think it's just about financial security. We don't think it's just about health care. And so we have these other areas in the index. This was published in 2 articles last year in Proceedings of the National Academy of Sciences. I've gotten permission from Alan to mention that. It's not that it got rejected by Health Affairs, but anyway, it got So these two papers were published in PNAS last year, and this is just the headline from the paper. And we think this kind of an index can serve as a guide to the implementation of policies and a tool by which we can assess their effectiveness over time and across different societies. And there are 5 domains. So we're stepping away from housing to financial security. Now I'm trying to step away from financial security to a broader set of considerations, because we think just thinking about financial security is a risky strategy for the support of an older population or the entire society. The first is productivity and engagement, which includes measures such as labor force participation over age 65, hours volunteering, well-being measures, the state of being healthy, disability-free life expectancy, plus a subjective measure of health. And all these measures are from the OECD. These are collected on all 31 OECD countries in a quite systematic and reliable way. Thirdly is equity. This measures the gaps in well-being and economic security between the haves and the have-nots in our society. This would be, for those of you interested in this, basically the Gini coefficient over age 65, for instance, would be one measure here. Cohesion. I read an article in the Financial Times this morning about uproar in Japan against the behaviors of older individuals. And ragao or something, I don't know how to pronounce that, don't know any Japanese, is a term they use for this. And it's really become a major issue in Japan. The annoying things that older people do is the way they described it. And it reminds me, my kids tell me, Dad, you're the annoying thing. Stop. And so cohesion measures tension across generations and social connectedness, and we think that's critical to the well-being of the entire society. And lastly, security, including financial and personal, physical security. And I'll just show you very quickly that each of these measures have 4 or 5 sub-measures, and there are network weights. These 12 individuals opined how much should this domain be. Dana Goldman thought financial security should be somewhere between 98 and 100% of the index. Some other people thought otherwise, and we worked out the sausage. What I want to show this slide because David just set me up. This is really remarkable, actually. I was unaware of this. But if you don't like our network weights, you can go to our website, agingsocietynetwork.org, and you can put your own weights in. And you can push the button and you can create your own index. Just don't call it the Hartford Index. Okay? So maybe this is a theme that the scholars are beginning in an effort to be transparent and share resources. It's interesting. The two of us independently did the same thing. So very quickly, these are the equity issues, like I said, the Gini coefficient, food security, which was really interesting, poverty risk, and educational attainment, et cetera. So we have 27 or so variables, and here is the way the countries stack up. This has been very well received. We were delighted that it was published in PNAS. We were delighted to be asked by the World Bank to present our work there. I was delighted in December to present this to the European Commission, as they've indicated their interest in using the Hartford Index as their official metric to follow European Commission member nations as they adapt to society. And I presented this at the OECD in Paris. And I mention that because I can't not mention this. So here are the scores. Basically, all you need to do is go to the Winter Olympics, look who is on the podium. You don't need to do your index. And I'm in the middle of this presentation, and a guy raises his hand at the OECD. Big round table. I look at the guy, yes, sir. He takes off his simultaneous translation headphones. He looks at me with a very heavy Northern European accent. He speaks in English, and he says, I'm from Norway, and I want everyone here to understand, for us Norwegians, the important thing about the Hartford Index is not that we were first, but that we beat the Swedes. So I look around the table, and there's a guy with a sign, Serge. I said, that's Sweden. I said, sir, do you have a comment? He just said, and that taught me all I need to know about Norway and Sweden. Anyway, to move on, here are how the different countries go along these different domains, and there's a lot of variability. The point is a country that's good at one thing isn't necessarily good at other things. And just to move along, you can see how different countries trace out, and they do much better at some things than others. Our postdoc, Cynthia Chen, came up with this, which I think is really cool. And that is, this diagram sort of shows the stronger you are in an area, the further you are from the center, okay? So the country in red there happens to be the United States, and where you look like, with this array, the most symmetrical. And we overall do very well because we have, despite the fact that I think it's too young, we have a fairly old retirement age compared to the rest of the OECD, and people retire later in the U.S., and that boosts up the productivity rating. But what's really interesting is if you look at Spain, you can see Spain's in yellow, and they do, well in security, and they're cohesive, and they're equitable, and their well-being is great. And the reason is that nobody works, and they all sit around talking to each other all day. And you look at productivity is like at zero. Are they happy? I don't know. If they're happy now, they won't be later. And that's where I will leave it. I would just like to leave you with one idea, and that is that one of our members came up with a really clever idea a couple of years ago, and that is she thought, what we need in aging policy is a societal aging impact statement. Like we have an environmental impact statement, and every time you pass a major program or policy or piece of legislation, you have to check the box that you did the environmental impact study. Maybe it hurts the environment, but maybe it's something you want to do anyway. Okay, but at least we asked the question, we know the answer. And maybe if we started doing that in a regular and routine way, in a standardized way with respect to the impact of an aging society, that in fact we'd make more progress. Thank you very much.
Well, good morning, everyone. Thank you for the opportunity to be part of this forum and this volume of health affairs. It's really good for us to see the important issue of housing and care for middle-income older adults receiving this attention. And Chris Herbert, the co-author on this paper and the managing director of the Joint Center, sends his regards. He couldn't be here today, but we're both really pleased to be here, to have written this paper. So, the growth of the number of older households is indeed unparalleled in American history, and as the leading edge of the baby boomers soon turns 75, we can expect this next decade to be one of tremendous growth. Our Joint Center estimates project that this 75-plus households will double in the next 20 years. And Caroline and David's work projects that just within this decade, we'll see the middle-income seniors double to 14 million. And that 20% of this group, as they said, will have high needs, but 54% of that group will have difficulty affording the housing that they need. So putting an estimate at quantifying this is incredibly important. We've seen this anecdotally for sure, that there are plenty of options for high wealth people and that there are some wonderful, creative things happening among the subsidized population, although not for everyone, certainly, and I'll get to that, but that there's this gap in the middle. And so quantifying it should help us think more concretely about how to serve this growing population. Our perspective sought to address the remaining group that will not have high needs, but will face some of the physical challenges and the health challenges of aging. So in other words, we're asking, what about the other 80% of the middle income? As the previous research has pointed out, most older adults will face challenges. 60% will have limited mobility of some sort. 67% will have 3 or more chronic conditions. So some of these older adults may well need different housing with more services in the future, but many could stay in their homes if only for the appropriate housing and support. Indeed, this is what most older adults say they want to do. Consistent with many earlier studies, a recent AARP survey found that 69% of people 75 and older strongly prefer to stay in their current homes as long as possible. Among the so-called silent generation, those who are already in their 70s, that rose to 77%. So staying in the community is clearly important. Staying in their homes is clearly important to people for some of the reasons that David enumerated before. And a familiar home in a community can have many health benefits. Older people have lived in their homes for a long time, most of them. The mobility rate for older adults is very low, so there's probably a very stable community network. People know their pharmacists, they know their physicians, their librarian, their religious institutions. A familiar home can offer a sense of control, even as one's health and functional abilities evolve. It can be an important reflection of self and a repository of memories, and moving can also be stressful and difficult. And those of you from the DC area and Massachusetts certainly know that people looking to downsize often have to find more money to do so, right? There's just not enough options to leave your single family home and move into something that's probably newer, more accessible, more centrally located. Those options are limited and they're more expensive. So aging in home is important, but as we know, the homes in which most older adults live are really not well suited to people's needs as they age. So a first challenge is accessibility. Despite the fact that 60% of those 75 and over are likely to have ambulatory difficulties, only 3.5% of today's housing is even minimally accessible to those who use wheelchairs or other scooters and devices. That we calculated this based on 3 measures of accessibility: whether the home is a single floor living, you have a bathroom and a bedroom on the first floor, whether there's a no-step entry into the home, and whether there are extra wide hallways and doorways that could accommodate a wheelchair. Totaling all those up, 3.5% of the units in today's housing stock have those features, but as some of you in the audience know, this might be overstating the fact, because there are some difficulties with the data in terms of how people report whether or not they have steps into their house. So this could be an overstatement. So basically we have a great gap here. Safety in the home is also important. So even if people do not use a wheelchair, more than a third of older adults fall every year, most often in the home. 70% of those falls occur in the home, in fact, often on the stairs or in the bathroom. So just thinking ahead before people have a disability and need accessible housing, how we can make housing more safer. And universal design and safety features such as the kind I talked about, the no-step entry, but also things like the walk-in shower, electrical light switches that you can reach from a wheelchair or that you don't have to bend too far to reach, lower cabinets, even that toilet paper holder which doubles as a grab bar. All these things are really important. A second challenge is that most older adults are not aging in cities and dense locations. They're outside in lower density suburbs and beyond. And when you look at the middle income group, they are the least likely to live in urban areas. So each group of these bars totals to 100. So if you look at that group in the middle, that's earning $25,000 to $100,000. That's their distribution across the metropolitan area. That green bar is the least dense part of the metropolitan area. So think your low-density suburbs, your exurbs, and then the purple is beyond the metropolitan area. That's in rural areas. So this is a concern simply because those areas are less well-served by transportation options. Getting around can be difficult. They're dominated by single-family homes, which have the aforementioned accessibility problems typically, but also are isolated from one another. And service delivery can be difficult. If older adults have difficulty getting around if they don't drive, so too do healthcare workers and family members trying to visit. And lastly, many middle-income older adults are still housing cost burden, meaning they still have affordability problems with their housing. Affordability problems we define as paying more than 30% of your income, and that bit in red is paying more than half of your income on housing. So we are seeing more and more older adults going into retirement with mortgages. That's true even for 26% of the people who own homes who are over 80. For some wealthier people, having a mortgage may not be particularly concerning, but for that middle and for lower income homeowners, for sure, it's definitely cutting into money that they could otherwise spend on healthcare, out-of-pocket costs, and food and transportation. So what can we do about these challenges? We drew a lot, actually, from some of the wonderful solutions that we're seeing at the subsidized level. And there are a host of things that we think could be expanded, as David and Caroline also mentioned some of the same things. Tax credits and other options that can help fund modifications in the home. There are a lot of programs out there, often for people who have documented disabilities and low incomes. But what if we could expand these, as some do, and as there are conversations at the federal level to do this, to people who do not yet have disabilities and do not have low incomes necessarily. A second issue is that older adults, and this came out in the AARP survey that I mentioned, know that they need to make repairs to their home, know that they need to make modifications to their home for safety and accessibility reasons, but it can be daunting, as we all know, to find that trusted contractor, to find the affordable person who's going to do the quality work. So having some kind of a vetted list of trusted and affordable contractors can help the individual. At the community level, there are visitability policies that are encouraging accessibility in future housing, so not necessarily helping an individual, but helping increase the supply of housing stock. Basically, these say that any new housing should be built minimally accessible or adaptable. The state of Vermont has such a policy, as do many counties and local governments. And finally, another great model that we might think about is the capable model, right out of Johns Hopkins, that combines a handy person with a physical therapist and a nurse to sort of assess somebody's individual needs and help them make those changes at an affordable price. Then there are some great programs that offer services to people who want to remain in their communities, such as PACE, the Program of All-Inclusive Care for the Elderly, or Supports and Services at Home, which began in Vermont, but I understand is expanding to other states now. Providing coordinated services and care for older adults who live in congregate care, but also nearby. SASH provides individualized healthy living plans, care coordination. So these kinds of things can help people who have health needs stay in their homes without having to move to more intensive housing with supports. I would be remiss if I didn't mention age-friendly communities. These are the things that, since many people are aging in low-density locations, we need these options. The options on the left are really the no-nos. The broken sidewalk, which is actually outside of a regional medical center, the sidewalk to nowhere, which populates my entire neighborhood, frustratingly, the lack of a sidewalk, and the solutions on the right, the paratransit, the accessible outdoor venues, so that we can see so that older adults can be in the community, they can get the exercise, and they can be part of our communities. And other aspects of age-friendly communities touch on some of the things that Jack mentioned, opportunities for engagement, services. And I want to end with this note that while I've been talking about aging in place, it is certainly the case that for some people, their current house may not be the most suitable place. It may not be worth modifying. And I think we need many more options for housing in these low-density locations in particular. So I'm speaking about accessory dwelling units, more housing in town centers where you can have a little bit of that walkability, you can have more of those amenities, you can have the accessibility. Other things like multi-generational or shared housing, certainly thinking about putting housing with supportive services in these locations that are not in central cities, not in inner ring suburbs. And lastly, I just want to note, as I started at the beginning, that while we think some of the benefits and options available at lower income models can be brought up the income ladder and really serve middle income older adults, there are still gaps at that lower income level. We only serve, according to HUD's worst case housing needs, a third of the older adults who have very low incomes and qualify for housing support. The green bars are projecting out the need in the future and just thinking about, can we even keep up with a third of that? So while there's some great ideas coming from there, we still must address the whole sliding scale of the income and need. So thank you.
We have a lot to work with here, and I'm going to ask a few questions, and we'll take then some from the audience as well. Let me start with David. You got a good chuckle when you said, "Don't count on Medicaid," but I was struck that the evidence you present shows quite slow growth in the low-income cohort from 8.1 to 8.9 million, less than 10% over 15 years. Presumably GDP is going to grow a lot more than 10% over 15 years. You've got 70% growth overall in this population, but very slow growth in the lowest income. Doesn't that, and I, by the way, all of you should feel free to weigh in, but doesn't that, I'm always looking for a ray of hope because there's a lot here to be worried about, but doesn't that offer us a little ray of hope here that actually there might be, just from straight economic growth, a smaller share of the population, even though it's a numerical increase, but it's so slow, a smaller share of the overall economy needed to support that lowest income group?
Thanks for that question. For those of you that haven't had a chance yet, and probably most of you, to look at the paper, what Alan's referring to is we observe relatively kind of slow expansion in low-income older adults relative to the middle income, which is a pretty interesting development. I would argue, I think you're right, that is a ray of hope, kind of to live up to the dismal science as an economist. What happens here if a lot of these middle-income individuals don't have other options and end up spending down? That's a huge cohort of individuals. And so I think given the cost growth we've seen in long-term care over the past 20 years, if that continues, these are going to be, on the intensive margin, very expensive services. On the extensive margin, this possibility of lots of middle-income elders spending down. That's why I'm somewhat pessimistic about the future of Medicaid. I don't know if others have.
Wouldn't it?
Those are on. I think you don't.
Well, it seems to me this is rather slow growth in the low-income elders is a direct consequence of the cohort difference in educational level. Right. It's been noted earlier. We noted higher education is associated with higher income and better financial security and better well-being, and education is still the best investment, right? So, I mean, that would be consistent with these data. That cohort of individuals who grew up in the United States before you had to go to high school is going out of the end of the population, and now we're seeing a fairly dramatic increase in the proportion of people with secondary education.
Yeah. Let me turn to some of the themes I think that came out more in Jennifer's comments. Another line that we heard today, and you hear it sort of in the first few minutes of any session like this, is no one wants to live in a nursing home. That's relatively easy to say, and everyone nods their head. But I want to try to pull that apart because we're talking about alternatives other than just staying in your own home. And so to me, the question is, what are the characteristics of the alternatives, not just staying in your own home, but assisted living and others on the continuum? What are the characteristics that make them superior so that we're not just either replicating no one wants to live in a nursing home, well, now no one wants to live in an assisted living, well, now no one wants to live in a congregate housing, no, and then we've created options that don't actually solve the problem, or to move it the other direction. People want to age at home. People want to age in a community. What would it take to make nursing homes more like those, which I know there's been a significant amount of effort to try to do. So I just want to take that sentence and ask each of you to respond and sort of think about how can we be more precise about what the characteristics are that lead people to either want or not want a certain setting as they're aging. Who wants to go first? Carolyn?
All right, you want me to start? I just want to amend the statement. I know I was one that said it first today. It always comes up. No one wants to enter a nursing home. I think no one wants to enter a nursing home as most of them are currently, constructed in the U.S. As Alan just touched on, there's been a huge shift with culture change and trying to reconceptualize a nursing home. And I think actually adding a lot of the attributes that I would argue we want to think about across the long-term care continuum, not just in nursing homes, engagement, autonomy, socialization. It's really your home versus living in an institution. I think those guys, Jack had a great list there of attributes. And I think trying to think about do we meet a lot of this? Would you want to live here? Would you want to work here? That's what I would focus on, whether it's a nursing home, assisted living, or living in my own home.
The other thing I think that's implicit in not wanting to be in a nursing home is the associated assumptions about what your health status is at that point, right? I mean, those are folks who have really high medical needs, right? Limited mobility, et cetera. And so I think the question is, to what extent do other housing options before people reach needing the level of needing nursing home care, can those other housing options help prevent that progression or slow that progression? And, the classic one is the grab bar in the falls. But if we don't have people's either, original homes or new homes, assisted living or whatever else, equipped in such a way to really care for them as their health slowly deteriorates, we may see a rapid deterioration. And I think that's another reason why it's important that we think ahead to this middle market. If we don't serve them, do they actually wind up sicker? And do we actually sort of accelerate the progression of health decline?
I would say I'm not sure that we know enough about how older adults make decisions about their housing. I'm a researcher, so maybe, of course, I would say this, but I would love to know more about what people know their options to be, what they consider, who's involved in those discussions. I know anecdotally that when there are spouses involved, often people have very different preferences for what they're going to do, what draws them to various more communal settings versus more individual settings. So I think that there's a lot to be done to think about when people say they want to stay at home, what they're actually considering is the alternative. I do think that one thing that is a draw to some of the seniors housing is the community aspect. So we know loneliness is a significant health risk and a severe issue for older people. So thinking about the community aspects of some of these places, I think, is important.
Yeah, I don't know anything about housing, but talking with patients and looking at this over years, it seems to me it's about dignity. People don't want to live in a place which has an implicit loss of dignity, and whether that's associated with the number of staff or the kind of training or the equipment or whatever. And I think from that point of view, my guess would be that faith-based facilities maybe have a relative advantage there, particularly if someone identifies with the organization which is supporting it. But I think that's the piece that gets lost as we try to solve this equation. And I think for many people, they're resisting going to places which implicitly erodes their dignity.
Let me ask one more question before I turn to the audience. Whether it's Jack's index and the answers to the last question, a lot about community and community support. I'm struck that in the program that I know best from the healthcare side, which is Medicaid, it offers basically individual benefits. You're eligible, you need a service, you get payment source for the service. When we step back and talk more conceptually, a little bit more where Jennifer was at the end of her remarks, we think of a community, not just for the engagement elements, which we were just discussing, but also the support elements, the access to the services you need that fill in for the things that you cannot do on your own. An image of, well, if people lived in dense communities with those supports, they would be happy. We are so far from that. And so what I worry is we walk out and say, well, there's the answer. We just reconfigure supports around the community rather than the individual. That seems like a heroic undertaking at the moment. So what can you all say about the nature of how we think about those supports now, how we provide them, and how they would what would we have to do to really reconfigure around what sounds like a combination of living circumstances and social supports as well as socialization that people want? Jack?
Well, I think there are 2 points I would make, Alan. First is I think that much of the need which is not being met, as you point out in the community, for supports is derivative of the relative weakening of the family as the traditional safety net, right? So families used to be kind of vertical and biological, and now they're kind of horizontal and voluntary, and they're spread out all over the country, if not the globe. And we know that the divorce rate's 50%, and stepchildren have less of a connection with the parents than others, et cetera, et cetera. So there's the need, and that has to be compensated for. I think one thing we could do, trying to be a little productive in terms of, is to face up to the dramatic age segregation of our population. We live with people like us in our age cohort, and we go to restaurants that they go to, and we go to vacation places they go to, and it just, if you think about the different cohorts in our society, there's a dramatic lack of overlap and cooperation and communal activity. You see it some in churches, but lots of places you don't see it. And you go to the YMCA, and all the kids are over here doing this, and all the old people are in the next room exercising. Nobody's together, not even in the cafeteria. So I think age segregation is an important target, and if we can be specific about what it means and show examples of it, and then we can maybe find ways to begin to erode it.
I think you gave us an out, which said we didn't have to walk away with a single solution to this massive problem, so I will take the out. I think, one of the challenges of saying we have this huge and rapidly growing challenge coming towards us that already exists today, but it is going to get bigger, is how do we create some massive policy solution to address it? And there have been valiant efforts along those lines in the past, and they've been met with unsuccessful ends. I think at this point, my guidance would be incrementally. There's so much unmet need. We should, incremental progress across all of the current avenues would go a long way. And so, you think about MA supplemental benefits that David mentioned. We've seen progress on trying to broaden MA benefits beyond just medical services. But the dollar value associated with those supplemental benefits right now is abysmally low and not realistically going to make a big impact. Some loosening of that or more investment of that could be helpful. We didn't talk a lot today about caregivers.
I'm just going to interrupt and say for the housing people in the audience, MA is Medicare Advantage.
Thank you. We didn't talk a lot about caregivers, and we know David mentioned that the baby boomers have fewer children. Their children are less likely to live nearby. The research thus far has said that while that trend has been in place for a while, a smaller number of caregivers are managing to provide the same amount of care. I think the question we need to ask is how long is that tenable? And as we continue these trends, is that likely to continue? Caregiver supports, investments in that sort of informal care is important. So I would say, designing the big long-term care insurance program is going to be really hard. Thinking about the pieces and building blocks that are in place and expanding them is good.
I'll just add on one quick point, and that's to say I really think it's central, Alan, that we engage the housing policy community. You come from a Medicaid background, many of us, in health policy or Medicare, Medicaid. It's rare that we kind of think about housing at a forum like this. And I'll just use a personal example. Jen and I work at the same university, but our research is completely siloed. That may say more about Harvard than this. But I think this is real, that housing folks work on one side and Medicare, Medicaid folks work on another. And so is there a way to kind of engage that? I don't know, Jen, if you had further.
Yeah, no, I agree. I mean, I think unquestionably there's a large federal role here, but a lot of this is local. So I guess I want to answer it from the local perspective. just as Jack was talking about having sort of an aging impact statement. Before I came to Harvard, I was a practicing planner, and I used to think there ought to be, just like we have a sustainability person at the city level who's making sure that what happens in each department is speaking to sustainability, we should have someone thinking about aging, because I know that public works and housing and planning are all doing different things with that regard. And if we don't make the built environment comfortable for older adults, then they're not going to be there mixing with other generations, which is to Jack's point.
So I have a career idea, which is we're going to start intergenerational music appreciation programs to reduce the unwillingness of the generations to mix. We'll open it up. I'll start here with Carl. We'll go back here.
Well, thanks,
and
Alan.
Please identify yourself and wait for my...
Carl Polzer. I'm not a well-funded member of the intelligentsia, but I have plowed in this research and policy area for decades. I worked for a major long-term care association on assisted living policy for 10 years. I co-chaired the long-term care discussion group. We meet every month and discuss these issues for decades. And I've done some research. For the Society of Actuaries 4 years ago, detected the same kind of vulnerability, and for the industry. What we're talking about is a massive funding problem, but what the solutions we're talking about are very around the edges. And I think if you look, also work on inequality and what's happening with our economy. The bottom half of our economy, the people have no savings, no net assets, and they don't have much income. And a lot of people are trapped in low-wage jobs. So I see the lower group growing. Now on Medicaid, I think
I got to focus you in.
Yeah, but Medicaid, this background. People run down Medicaid, but here's my question. Medicaid is a universal coverage system. We don't have that even for health care. It just isn't, the benefit isn't what the middle class wants. You have to spend down. The benefits are pretty good for the people at the bottom. So one thing to consider is not to dismiss Medicaid. I think it'll be more supported. It's a de facto social insurance program, but it started out as a welfare program. As voters realize this, and there are more older voters, there's more potential for reforming it. So ideas to reform it could include, raising the asset level, raising the income level, including more people so they can buy more things on the way as they spend down for themselves around the edges. And I do agree about the housing completely, that assisted living, although states could also step up to the plate on that. But I think Medicaid is where to start.
Reactions?
Yeah, absolutely. Kind of another kind of lever we have is to increase kind of Medicaid generosity. Going back to the earlier exchange with Alan, how much enthusiasm states will have for that is unclear, given it's more spending, and as long-term care makes up a bigger and bigger part of the Medicaid budgets, it's unclear to me if they're willing to go down that path. But I do agree there are ways, whether it's covering long-term care and Medicare or major expansions within Medicaid, to really go at this in a bigger way. I think these would be pretty substantial reforms that we're talking about today, but there is a whole nother step along a continuum where you could go much further.
Let's go back here. Well,
we should call up Bob to answer that, but I'll do my best. So I don't know that I can speak to specifics. I think there is a lot of experimentation. I mean, historically, right, the industry has been built and been very successful at serving this very high income population. I do think there are examples throughout the industry of folks who are thinking more creatively about alternate solutions, whether that be, somewhat lower amenity, more sort of rental efficient options, different structures of housing people. And I think that I'll just tee up, I think the next panel is going to have some of those folks up here. So they'll be able to give you some of those examples more concretely. But I would say we're sort of in the experimentation phase, and we hope to see that really take off. So I'm
going to take one last question here on the aisle.
Thank you. Lindsay Hutter with Goodwin House Incorporated. We're a senior living and care organization based and operating across Northern Virginia, and is a senior living and care organization that squarely put the mid-market in our new strategic plan. I want to thank NIC, Health Affairs, NORC, and all the panelists for the invaluable research that you're bringing to us. My question is posed to Carolyn. In your data points, I think you said 67% of older adults that are in this cohort you studied will enter their retirement years with 3 or more comorbidities. My question to you, is that number higher or lower? And I realize you didn't study precedent to 2014, but is it higher or lower than the silent generation? And if so, is there any analysis you can give us on how we have more access to health care and higher educated older adults, but potentially an increase in the number of comorbidities as they enter retirement?
Yes.
Thank you.
So, and unfortunately, I don't have my 2014 chronic condition numbers right in front of me at this moment. Generally, as a methodological issue, we felt that we didn't have enough research to support projections on how rates of chronic conditions are going to change. So for each of the sort of demographic subgroups that we looked at, we assumed consistent rates with what we see among people 75 and older today. And so I think there's actually a lot of good questions about in what ways do we think chronic conditions are becoming more common. On the chronic condition side, they are. But on the other side, are we seeing things like cognitive impairments potentially going down? We just don't have good enough literature right now beyond the sort of obvious things about rates of chronic conditions across the population. So we just took that conservative estimate.
But clearly, this is a variable that when you slide with the assumptions, this is one you can play with, and it would have huge implications. I know there are more questions, but we have another panel that's going to bring in exactly what the prior questioner asked about. So please join me in thanking our authors for their presentations. I'm going to ask our second panelist to come up. I'll introduce them as they make their way to the front. In addition to Bob Kramer, who's already been introduced, you'll be hearing from Debra Whitman, Chief Public Policy Officer at AARP. You'll be hearing from Nancy Eldridge, CEO of the National Well Home Network, and Hsiao, CEO of Eclipse Senior Living, which is a third-party manager of independent assisted and memory care communities in the United States. And we're going to try to make this a little more discussional, if that's a word. If it's not, my apologies. To try to tease out some of the themes that came up in the papers, but to take them more squarely into some of the policy discussion. So as you all are getting seated, I have a few questions, as with the first panel, that I'm going to ask. I'm going to sort of start with one person to tee the conversation off, but then, of course, I will hope others will jump in as well. Deb, let me start with you. We talk this morning primarily about housing, health, long-term services and supports. Jack's slide showed people at risk of having zero, which means nothing. So as important as housing, health, and long-term services and supports are, those are not the only needs people have as they age. Given your work at AARP, can you put the needs of health and housing and social supports in the context of other needs that seniors have?
Sure, and I'll actually paint a fairly bleak picture on top of everybody's bleak picture, and also take the holistic view of the population, not just the middle income. Jennifer showed us earlier that about a third of people between 50 and 80 spend more than 30% already of their income on housing. And if you get into the 80-plus-year-olds, it's about 40%. So money is going out for housing, even if it's not for housing with assisted supports and services. And it used to be that people would pay down their mortgage and have that as an asset so they wouldn't have those expenses in retirement. But we've seen housing become the main asset that people have, and they're drawing out income and assets from it throughout their working lives so that when they get to retirement, they still have a lot of housing debt. A paper that ARP released a few years ago showed the fastest rate of foreclosure growth was for people over age 75. Now imagine losing your house, whether or not you need services, at age 75. Another thing I'd like to talk about is how little people have saved. We have an abysmal savings system here in the United States. If you have a good employer like ARP, we have a 401k, we have a match. But about half the population either don't work for an employer that offers that or don't qualify because they're part-time or they're in their first year of work. And so even if people want to save for assets for their future, we make it really, really hard in this country. One of the things ARP is trying to do is pass laws within states to set up state-based retirement plans. And we have Oregon that's already kicked off theirs, Illinois, which is about to start in California. So this will capture those people, but it'll be a small amount of savings, nowhere near that 10, 12, 40% that Jack's slide had. The other point I'd like to make is that yes, they're spending other money on other things like gifts for their grandkids or potentially a new blouse now and again. But the health care costs that are out of pocket are already absorbent for most seniors. A Medicare beneficiary, just to put it in perspective, on average has about $26,000 of income. Median Social Security benefit is about $16,000. So we're not talking lots of money that people have to spend. And we funded a report by the Kaiser Family Foundation that took just your Social Security income and said, how much are you spending of that on out-of-pocket health costs? And that includes premiums, co-pays, long-term services, and supports costs. In 2013, those healthcare costs ate up 41 cents of every dollar on average of Social Security. Now, we know Social Security grows at the rate of inflation. Healthcare costs grow quite a bit higher than that. By 2030, it'll eat up, on average, half of your Social Security check as your healthcare costs. And that's much higher if you're sicker. It's much higher if you're older. So this is the number that I repeat as often as possible, and I hope you will join me. Right now, if you're 85 plus, about 71 cents of every Social Security dollar is going to healthcare costs. By 2030, it's 87 cents of every dollar. So you can pay for your housing costs out of those extra 13 cents, as well as all of the other things. Forget the blouse. And this week we had the Social Security Trustees Report, which in 2035, the exact year I turned 65, showed that the trust funds will no longer be able to pay full benefits, and benefits will need to be cut by 20%. So that 13 cents will be taken away unless we do something. So all of these pieces show the financial precariousness of the general population. They're already spending a ton on health care. They have very few savings. They haven't a lot invested in the home as it is. And so when we think about the future financial state, even those in the middle class feel anxious. And that's where you get all the worrying index that we've got tons of research on of people's financial and other futures.
Well, that was cheery. Thank you.
Anyone need coffee?
Anyone
now?
want to offer another view on this that's can be equally bleak, but other perspectives on the role of other needs.
Well, I don't think there's really dispute about the numbers. I mean, one of the reasons we're trying to shine this light and bring attention on this middle-income cohort, and many of them are fearful that they're one incident away from being in poverty, a health care bill they can't afford. And in fact, one of the issues when we separated out tapping your home equity versus not was that for many, that's their last nest egg. And what you see is a pattern of gradual decline in, for instance, their health and social supports, but they don't want to spend the actual money they have because it's a gradual, imperceptible decline versus that dramatic moment. And they feel like they've got to have that nest egg for that dramatic moment. But ironically and sadly, I mean, hearing aids. Many are into almost voluntary social isolation, which leads to depression, simply because of hearing loss. But they feel that they're fearful to go down that road and to explore it. So I think the fear factor is huge, and something that some of the previous panelists mentioned is social perception is key here too, because a lot of research shows that many seniors basically reflect the attitude society has towards them. And once you start feeling of yourself as worthless, no longer having value, you don't put as much effort into caring for yourself and engaging with others. So, you know, even the perception of many seniors housing and long-term care communities becomes a reinforcing thing of people wanting to fear it even when they need it. And that's why it's so often that, you know, it's so important for people to actually, when people have experience with nursing homes for a loved one, they usually have a very different attitude than the general society does.
Yeah. Look, you know, I think I'm going to sort of pivot a little bit and sort of look. I think we all understand the numbers, and it is a little scary out there. Let's flip it, though, and also say I think there's a lot of opportunity out there as well. Look, I speak as a senior living operator right now. One of the things in senior living that we've always had a question about was why has our penetration rate been static around 10%? And I've always said it's probably because we haven't built anything the other 90% like yet, right? And I think that's also because we haven't targeted this middle income group. Imagine what the penetration rate would be if we actually started to do that. On the other side, another point too, in the senior living, for those in senior living right now, one of our big challenges is occupancy and due to oversupply. If you take a look at what's being built out there today, I mean, the fact of the matter is it's all the same. It's all the 80-unit AL, 20-unit memory care, 100-unit-ish, $4,800 RevPOR targets. Everyone's building the same thing for that upper income market. Again, I think a lot of our occupancy woes and oversupply woes could be lessened or dampened if we actually targeted that middle income demographic. So again, yes, there are some challenges out there, but I think that also leaves a lot of opportunity for folks like us in the senior living space right now.
Nancy, I want to bring you in. I mean, one of the challenges here is we appropriately sort of divide the population into these categories, and again, you can use the slider on the website to move them, but there are sort of those with very limited resources who are likely to rely on public programs. There are those who as Kai said, have been targeted by a lot of the building, and then there's the middle. But people's income doesn't tend to change that much, but their needs certainly change over the course of their lives. So how do we not just sort of think of these as separate markets, but thinking of them as meeting the needs of a population with quite a diversity of circumstances and needs?
Sure. Thanks, Alan. I think it's really valuable that we've learned more about the middle senior market and the characteristics of that market. I think that in no way means that we should create another siloed program, another intervention, another system for that distinct population, that distinct income category. I've been working on this issue for 20 years or more. Started as a houser and moved into healthcare, So I've been working on integration of health and housing and social work, social services for many, many years. And the reason that I developed the SASH initiative in Vermont, Support and Services at Home, was that I felt like we needed one system. You know, we're seeing the baby boomers coming through. Well, in the 1950s, HEW was made a cabinet-level position because of the education needs of baby boomers. In the 50s, the baby boomers were in first grade, second grade, third grade. And this country really improved our public education system to support the needs of baby boomers. What we need for seniors today is nothing short of that kind of robust system that supports everyone. So we created SASH thinking everybody wants to stay at home, and those who don't probably will anyways. Some will move, but the vast majority will stay at home. And we started mapping out where people live. In affordable housing, in Vermont alone, there are 140 low-income, publicly assisted housing sites. 140 in rural, urban, everywhere. So you have this platform. You add to that platform where everybody else lives. Luxury condos, very rural farmhouses, very remote, very isolated. And you map that and you see an amazing platform. It's like we, back in the 50s, were developing an education system where we didn't have to build all the schools. The platform is built. And so then what do? The thought was, let's connect everybody who is not just a resident, they are also somebody's patient. So let's create an extender relationship between the primary care world, the hospital world, housers. And so SASH started developing those formal relationships so that hospitals understood, we're the ones that can take your patient home. We're the one that can get that person discharged from the nursing home as soon as clinically possible. No more medical miracles on day 90. You know, they're coming home when they're ready. And then, of course, we were all suffering with the silos. You know, AAA is doing this, mental health agencies doing that, home health just hamstrung by the way they are funded. So bring down those silos. Let's work as a team. You know, we always said when you come into the SASH door, put down your gun and put down your ego, because we're all one organization when we're in the SASH room. We're all talking about panels of seniors that need a whole range of help. And serving all incomes was critically important. Medicare was our first funder, and Medicare said to us, we are not a means-tested program. You must allow the richest Medicare beneficiary and the poorest Medicare beneficiary to participate in SASH. And I was like, thank you. That's exactly what we need. Let's stop compartmentalizing people into little pots and dealing with them differently. And then we realized we had to have a lean program. We had tried assisted living, Medicaid assisted living, lost our shirt on it. So we needed a lean program that could be very broad, all across the state, and so decided a part-time wellness nurse and a community health worker full-time would be the lean team that would be able to be nimble. People say, do you have to have a master's in social work? No, you have to be nimble. You have to be able to deal with whatever comes before you, whether it's the most complicated mental health issue or the interest in prevention. And we wanted to save money. We wanted to bend the cost curve for Medicaid and Medicare in a statistically significant way. And we have done that in both programs. And we wanted to have a value-based payment method because it's flexible. We wanted to get away from coding and dealing with a particular narrow issue and then discharging the person off the support. No discharge. Never.
So I want to take these elements. A lot of what's going on in healthcare right now is we're looking at health systems accountable for the cost of the health services, and they're seeing that people have social barriers that are driving health costs, and they're figuring out how to invest in them. I listen to you. I turn to Kai and I turn to Bob, and I say, you are investing in platforms that need people who can live successfully in them. Don't you need to invest? Is there a way to invest in the social infrastructure that then makes it more possible for people to live in those settings? Or is it just a separate, that's sort of a given?
A couple of comments. First of all, to what Nancy has said, amen. We need the size and the sheer numbers of elders is we need all of the above, not to choose sides and say I want to do this or I want to do this and I'm going to pit my effort against your effort. That's enabling people to stay safely at home as long as possible is a huge plus. It will save the healthcare system a lot of dollars, and when it's appropriate and people can live there, fantastic. I do think that one of the encouraging things, and this speaks to an earlier question or from an earlier panel, one of the encouraging things now is that I think with a growing understanding that health does not equal, or health care does not equal health, that there are a lot of other drivers and shapers of health and ultimately of well-being and quality of life. And I think with that, combined with the understanding that, especially for seniors, increasingly health care will come to them rather than taking them to health care. They, the consumer, will demand it, technology will enable it, and payers, especially managed care payers, will pay for it because they realize it's going to save them ultimately on their health care spend. Given all of that, I think it's fascinating to see experiments like Juniper Communities, an assisted living provider, where they created an integrated care management, care coordinated platform in their assisted living communities, where teaming with primary care physicians, teaming with therapy providers, requiring everyone, whether or not they had their own data reporting systems, they all had to report through one system, so there was instantly shareable information, establishing and paying themselves for an MC or medical concierge, who not only coordinated all the care providers, the social workers, everybody, but also coordinated with the family and the resident and made sure that there was a resident advocate. I think it's exciting that we're seeing housing and health care and long-term care all come together in the approach in this research and in this session today. But the one thing that can be easily left out ultimately is the senior doesn't want to be viewed. No individual wants to be seen as a sum of their health care, their long-term care needs, or their housing needs. What they want, and other panelists have referred to this, ultimately is quality of life. And quality of life is ongoing connection and engagement and purpose, as opposed to what so much of our society does is you reach a certain age and you become invisible. You literally disappear. And you disappear then into age-segregated communities where you only encounter people that aren't your age as staff or as your kids or grandchildren. That's going to stop. That's got to stop in the future. But my point here is the consumer's perspective, the senior's perspective, is they want quality of life. That's social engagement and connection and giving people a sense of meaning and purpose. I love to quote Lisa Ryerson, president of the AARP Foundation, because she had a great comment. She challenged senior living providers and said, you've got to repurpose your activities directors as purpose matchmakers. And I loved that because I think that's exactly part of what we need to be doing in the future. So again, there are experimental platforms, a lot of them going on now, where we no longer, so to speak, need to ship out seniors to the hospital, to the ER, to the doctor's office. And secondly, where ultimately you realize that it's not just quality of care, it's quality of life. And you're looking, first of all, at what are the quality of life things that those residents want. If you're not delivering on that, good care is irrelevant because the person really isn't getting what they want.
Look, it's going to take a village to get at this, right? So, look, on the real estate side and the development side, how do we actually build a product that comes in less so that we can actually hit the price point that we want, right? How do we source the land? The land may be in more rural versus suburban areas, right? How do we construct it so it's less? It'll probably be more prefab than not. How do we actually, from an operator standpoint, how is our business model different so we can get to a lower cost? Our staffing models will probably have to be adjusted. What services we provide may be adjusted. Our food delivery may have to be adjusted. On the senior living side, labor is one of our biggest challenges right now. How can we get help from other organizations or other sources on the labor side. Look, I remember, there was, years ago, the United States was losing the Cold War to Russia, and, we funded a lot of education for people to become scientists and whatnot. Look, we need help with caregivers. Can we get more people into that role and providing them the educational resources to become caregivers out there? So, there's the full array of, of different functions that have to come together to sort of address this issue here. It's not just on one side.
So, there are two major trends trends that are affecting the demographics, and we spent a lot of time on one of them, which is a higher level of education leads to actually a smaller share of low income. We spent less on the other one, which is the increasing racial and ethnic diversity of the population. And I just wonder, I'd like to toss out to each of you, how does that change affect the thinking, the needs, the supply? Have we really paid enough attention to that shift?
No, we have not. We are seeing publicly assisted housing where the populations are a mix of Russians and Asians and Hispanic, and have very little interpreter services, have virtually no community health worker relationship in those communities, so that people's cultural needs can be met and their healthcare needs can be met in a respectful way. So I think it's a silent issue that is growing, and we need to really think carefully, no matter whether somebody lives in public assisted housing or the middle senior population. We really need to think about culture, language, different expectations and needs.
I'll also say there's huge differentials in caregiving and the sense of responsibilities. I was really struck by the middle. Basically, the only safety net is your family to take care of you, because you can't quite afford paid care and you can't qualify yet for Medicaid. Not only are we becoming more diverse, and there are different sort of social systems amongst different cultures of who takes care of who at all costs, but also the number of caregivers per person that is going to need it. So as we project into the future, Lynn Feinberg on my team estimated that in 2010 we have for every one person in their 80s which are most likely to need care. In 2010 there was 7 potential caregivers per person. By 2030 that's 4 to 1. 2050 that's 3 to 1. And so even as this middle market grows, their needs grow, the number of people that can provide that care. We've also done some really interesting work on millennial family caregivers, and how many people are, even in their 20s and 30s, having to step out of work to care for a father who has Alzheimer's. We had an amazing dinner with a whole bunch of folks here in DC that I got to attend. And there was one woman that just sort of broke my heart. She had to leave her job to take care of her father. And she said, when I got back to work, finally was able to, gave me my job back. People were like, where were you? Where's the baby? And all I had was my dead dad. And so there's a sense of this pressure of what we were talking about today really being born as much by the older adults and their need for care as their families are having to provide it. And so I do think this is all related and going to be a real burden, as I think Jack and others talked about, as we've expanded across the country. Our geography, my parents are in Washington State, not exactly something I can drop by in the evening on my way home from work. And just as the general populations are growing at the older end and sort of shrinking at the middle.
Yeah, I think this caregiver shortage issue is huge, and I think it's one of the areas where we have to think much more creatively and out of the box for solutions. And I think we can look, as David referred to earlier, we can also look to the experience of other countries, the involvement of family caregivers and other unpaid caregivers, volunteers, which now, from a regulatory and legal point of view, is virtually impossible. I worked almost 20 years ago now with a major national assisted living provider that was approached by a large African American congregation, very large, more than 10,000 members. And they wanted to have an assisted living, an independent living community built for their members. And the thesis was they had a huge congregation, very family-oriented, and that the members would provide a lot of the labor in the community. Not all, but a lot of it, to defray the costs. And there was a lot of excitement. The assisted living provider wanted to do it. The church wanted to do it. And the regulators said no way. And the lawyers said no way. Liability risk, unlicensed caregivers, you name it. And the whole project collapsed. When you look at other countries, their use of less frail elders to care for more frail elders, as in Japan, their use of family members to have required hours as a way of defraying costs. There are lots of things that could be done that we don't explore in this country that we're going to have to think about, because as Kai mentioned, and we're all saying, caregiving is key. The housing piece in one sense is the easier piece, because ultimately for many people when they move in, they have significant care needs, mobility, cognitive impairment issues, and so forth. And there's real care that's needed, and it's the cost of that care, which is usually going to be 60% to 2/3 of the operating costs of any community, or for that matter, it's those care costs and those caregivers if they're going into the home, in basically home care. Yeah. So wherever the care is going to be delivered, we have a caregiver shortage.
Yeah, and even for paid care that Kai was talking about. And you're right, other countries are thinking more innovative ways. So in Singapore, you either get a larger apartment or cheaper rent if your parents live in the same building, because then you have that ability to drop in and provide that care. In Netherlands that I visited, they're moving students into long-term care facilities into empty rooms to bring life into the place where the students don't have to pay for their rent. And so it's, I think we're going to need to think creatively. And I know, as Kai said, as we have tight labor markets, we're also looking at, really hard time filling these roles. Mm-hmm. They're tough roles. They're physically demanding, they're emotionally demanding, and we don't pay very well. And so that whole spectrum of caregiving is going to be really, really crucial.
We get approached all the time by developers, and they show me the feasibility studies for their development, and I'm saying, well, where's the stat for access to healthcare labor? Because at the end of the day, if you can build it, great, but if you can't staff it, it doesn't matter.
Yeah.
So.
This is terrific. We do have a little bit of time for some folks in the room. I see two here, one here, and that's probably going to get us to the end. So,
Hi, Louis Tenenbaum, Homes Renewed. We're working very hard to see the need to update the housing as an infrastructure, not unlike creating the solar grid or the plug-in battery grid for cars, that we need to just update our housing infrastructure and that policy can get behind that. And my hopeful note that I wonder if you've thought about, Nancy, it appears that you have, is that the combination of the technology people talk about and creative integration and the infrastructure upgrade can, I think, lead to a network effect, that all of a sudden, if you have lots of people in the neighborhood who are aging well and can get in and out, then your adult day services, your meals delivery, your transportation system can grow in a way that we can't really imagine now. And has anyone started to put numbers to the idea that different demonstrations and experiments can lead to whole different ways to imagine how the financial structure of long-term services in better designed homes can work in the community?
What we're looking to do is to bundle up services and arrive at a capitated amount that is affordable, but also look at it from the revenue side. We've started to do private pay, SASH, in Vermont. There are some housers that are willing to pay privately for their entire resident population for this. There are individuals that are willing to pay privately. And I also think we really do need to look at the existing equity in homes just a little bit through a lean and pooled And then of course Medicare Advantage is going to be a source. But I think Jack maybe used the word horizontal. I think we are trying to move from a very vertical, linear, patient to a particular program to a more horizontal look at what are all the resources, what are the needs, how we can align them in a more logical and commonsensical way.
Right here, next.
Thank you. Hi, I'm Dana Bradley. I'm the Dean of the Erickson School of Aging Studies at University of Maryland, Baltimore County. First, a shout out to the previous authors, on the panel. I'm teaching a class in the kind of the use of research data in the management of aging services this summer, and I'm so excited about these databases that we're going to be able to use. We're going to have so much more fun in June. So thank you. All right, so I'm in the business of identifying, nurturing, and supporting future leaders in this field of aging services. So here's my big question to the panel. What would be, and I'm going to say not the, but a question, critical question, that I should put forward to students who are entering this field, particularly in going to be looking at this middle market? What kind of critical question should they keep at the forefront of their work, not only when they're working with me, but when they graduate? Thank you.
That's a great question, and please send us more people. I talk to a lot of student groups, and I talk about how this is such a growth industry that nobody has discovered, and that there's all kinds of different opportunities, whether they're in health or income or all kinds of different areas. So I think inspiring them to see potentials. What I like people to see also is designing for the people for what they really want. I think this came earlier into, do we have the right housing for people? And if we design really well and have a universal design perspective that's human-centered, that values the individual as a person, actually lots of people want to be there, right? And so, if you think of OXO, which is the typical example of creating a grip for somebody with arthritis, that now I have half of my kitchen utensils from that company, I think inspiring them to think of creative. We've done a program with Pearson School of Design, getting fashion designers to think about all bodies and all needs. And the inspiration from these students was really, really fantastic. So that's my advice.
I would say think about what person or people have motivated you to get into this field, and hang on to that passion and that reason, because it's rocky roads. And for me, my disabled sister is the one that keeps me, when things get tough, you just go, poof, keep working.
And I think that a passion and that understanding, in other words, I think anyone coming into the field, it's really important they not only understand but stay in touch, as you said, with why they're in it. Because we're not going to see changes overnight. In societal attitudes, in different programs, you're going to have to be persistent. And you're going to have have a long view strategy, or you honestly won't make a difference. But if you hang in there, there's an enormous entrepreneurial opportunity, because you have this huge market. As Kai said, for instance, in seniors housing and care, 10% penetration, that means we're not doing something right with the product. Well, that's a huge opportunity for entrepreneurs. That said, it's also a huge opportunity to do well while doing good, because it's a huge social issue, and it's a social issue that's really key for the country to face. And are we going to have more and more sense of competitive forces by age for limited resources? Or as I hope, will the boomers, one of their biggest contributions to be to retire the second half of the 20th century notion of retirement in the U.S. and to start thinking of lifespan completely differently. And so we don't have people who live in our communities that are separated from the rest of culture and society, A, and B, who are known for what they did and who they were, rather than known also for who they are and what they do. I think that's a key shift that we have to do in thinking about this field. And too often, the very people we're serving are in the past tense. That's wrong. And so I think it's understanding their own attitudes towards aging and the aging is really critical, and why they're in it. Because we want them in there for the long haul.
Yeah, I'll just add one last thing. Look, I didn't come from senior living. I didn't think I was going to be in senior living. Before getting into senior living, I worked at Canyon Ranch and Healthy for the Wealthy. My biggest concern was, did Mariah Carey get her peanut M&Ms, right? So and then you got into senior living. You realize, when you have a daughter comes to you and says, "Look, my mom came to me, with just ailing. Dad just passed away, and she felt empty inside. Now she has friends she never had before. Now she has a purpose, and she's happier. And I wish we could have done this sooner." If you can remember that piece of it, I think and remember why you're doing it. I think it's a great reason to be in the industry.
Okay, I've promised 2 more people, and I'm going to have to keep you quick. We don't run over by more than a couple of minutes at Health Affairs. So right here.
I'm Dr. Caroline Poplin. I'm a primary care physician, also an attorney. And what I'm concerned about is the workforce. The workforce that I've seen, and my mother just passed away at 94 and a half. The money all goes to the middlemen. You haven't mentioned profit and nonprofit, or distinguished between profit and nonprofit, or between Medicare and Medicare Advantage. The logic of Medicare Advantage and Medicaid is that if you provide some supports and some home supports, that people will not go to the hospital, which is the most expensive part of the healthcare system. And if Medicare Advantage is allowed to offer it, Medicare also ought to offer it. The problem with the for-profits that I've seen as an attorney working on nursing homes is that the for-profit industry has destroyed nursing homes by taking money out of the system instead of reinvesting it.
Reactions?
Look, in regards to the middleman, I think last week I was at a conference and I said that I think one of the largest providers of senior living in the future will be health insurance companies. And I believe that because they'll see the benefit of maybe controlling that that vertical block and saying, hey, look, maybe we can get to it in a better, more efficient way. So that's a challenge to us in the industry to prove to them that they don't need to do that. But so far, I don't think we've risen to that challenge yet.
Yeah, I think too that understand from a government policy point of view, what's driving everything is not quality. Things are dressed in quality when they're about cost. And ultimately, what is driving so much experimentation, first under the previous administration and now the current administration, which in areas of offloading risk from a state in terms of MLTSS or from the point of view of the feds to Medicare Advantage. Policymakers, it doesn't matter whether you're a D or an R. They're all pushing that. Why? Because they're scared to death of the costs and they realize we've got to do something, we've got to change. So I think the issue is more how do we ensure this is done well? Because the reality is I just don't see the federal government in terms of Medicare or state governments in terms of Medicaid continuing to hold the ever-increasing risk of it basically ensuring those long-term care and health care costs. So, but understand it's driven by cost. So therefore, those of us that want to see quality and want to see all the issues that are just as important as cost are going to have to be in there all the time advocating. So, and there are legitimate questions. Does being public as a nursing home provider, is that in order to have where shareholders are focused on quarterly returns, can you do the right thing for the long term at a time where there's a need to invest? For a sector that's been financed so much as a real estate product, when the reality is the greatest needs for investment are on the operating side, on staff, in technology, and in systems. So I think you raised some really important questions, But I think at the same time, I think it's critical to see the drivers overall of our healthcare system, where it's going, one. And two, to understand that ultimately the solutions are not going to be to pit for-profit versus not-for-profit. Ultimately, the issue is who can best deliver the care. And partnering folks, regardless of tax status, around that is key. And with that, it's going to be getting entrepreneurial capital, and that capital, as I'll argue in my blog, which was posted today, one of the options is going to be, when we talk about the middle market, who are they? Well, the middle market are teachers, first responders, they're nurses and other healthcare workers, they're trade union members. You know, the largest source of institutional money in this country is pension funds. Do you know who those pension funds have the fiduciary responsibility to manage the retirement savings of? The very group I just described. It's state workers, it's city and municipal workers, it's trade union members, teachers, and so forth. So there are opportunities here because they need to have a stable, consistent, non-volatile return, but they're also ultimately managing the very retirement dollars and savings of their members, for which they have a fiduciary responsibility. So okay. I don't think just seeing this as a for-profit, not-for-profit is, we got to be aware of quality concerns no matter who's doing it.
The danger as we build one housing-centric health system in this country for seniors is that we will create new middlemen. We're going to be looking for aggregators, integrators, and connectors, and we must avoid that. We must resist that because the cost of this model is so thin in terms of the balance between volume, density, and cost of the system. Let's not make that mistake again.
Very last, very quick question. Sorry, Nora, it's the person. No, sorry. I saw you jumping up.
Oh, boy.
It's a good thing Nora and I are friends.
Right, thanks,
Kelly Cronin from the HHS Administration on Community Living. In the spirit of incrementalism and making good progress based on existing authorities and all the private sector innovation, what are the most impactful federal policy changes you could think of that we could pursue?
Quick answers.
Make health homes a Medicare, Medicaid product, not just a Medicaid product.
I'm actually really excited about what's going on at the states with age-friendly communities. It was mentioned communities should be age-friendly, but we've now got 353 communities where mayors have committed to looking across different sectors. We now have 3 states. Florida just signed yesterday. I think if we as a nation took the principles of age-friendly communities from the World Health Organization and integrated our housing, our healthcare, our transportation sectors and all of those in a broader way. Nora, I know, I'll give you a shout out. I know you tried to do that with the White House Conference on Aging, but we really actually need to do that. And so let's take this bottom-up approach for the states and communities are having all kinds of lessons learned and take that nationally. And let me just give one shout out for our livability index, which you can also change the measures. Rodney is here, who is my housing expert, and this measures livability at the community and neighborhood level. Thank you, Rodney.
I'll go low-cost caregiver student loans, tax credits for caregivers, and then I think right now as a parent you get a child tax credit. I think as a child you should get a parent tax credit too.
Bob, last word.
They're all great suggestions. Again, to my mind, it's like we need all of the above. And one of the things I'm most committed to, and as you can see I have a little bit of passion about this topic, is that the challenge is so big and the need is so great that we can't, within the community of those who care about it, fight with each other about whose solution is better. We instead have to work together because that's the only way you're going to get a focused national consciousness around these issues. If we spend time fighting each other, as a former elected official, there's no easier issue to ignore than the issue when your constituents, when 3 different groups come to you and all say they have solutions to a problem you should address, and it's all the same problem and they have 3 different solutions. That's a much easier issue for you to ignore because you know that if there are 3 different solutions to the same problem and you go with one, you've just ticked off as an elected official 2/3 of your voters. And particularly in today's daily polling, that's usually not a good move. So we as an aging community, aging services community, we've got to work together. And if we don't, we won't get any of the changes all of us here and the previous panels want to get.
So we heard a lot today that's empirical, that sets the course for a discussion, and we heard some things that were concerning, cause for alarm and reason to worry. As we close out, I just want to offer 5 quick observations that made me feel more optimistic. One is we're looking at a future population that's more educated. That's not just about income, it's about the other resources that a more educated population brings. Number 2, as Nancy pointed out, if we think of the existing housing, even though it has many limitations, if we think of it as an asset and a platform to build on, that's something that we have and not just something that we're missing. Third, as Kai and others pointed out, the field of assisted living and what we're building there it's still pretty young. There's a lot of room for innovation that we haven't yet seen, and that the youth of the field does create opportunities for models that are at this point underdeveloped. Fourth, we should not be naive about the possibility or overly optimistic about the possibility of improvements in health care, reducing the health burden of the population, but a major factor in the modeling is assumptions about the health status of the population. To the extent that technology, early interventions can lead us to reduce the disease burden and daily living limitations of this population, that's a tremendous opportunity. And I will close with, we're having a conversation, and we're looking at problems that exist today, but we're trying to understand what they will look like in the future. We have not enough time, but we do have time to try to build on the evidence base and try to figure out how to respond to it. So in addition to thanking my panel, since this will be my final words, I also want to say that we appreciate the National Investment Center for Seniors and Housing Care and the support of the SCAN Foundation, the John A. Hartford Foundation, AARP, and the AARP Foundation for their support. We hope you found this interesting. Go out, slide all the sliders that you heard about, and let's continue this really important conversation. Thank you all so much.
Nancy, it sounds like you're doing amazing work.